Hey everyone, let me know if you can see and hear me. Start here in a minute or three. All right, perfect. Thank you. Thank you, Araceli. If I'm saying that correctly. There's some questions up on the board, so I'll get started with that. And then remember, you have a test next week with me. So if you have any questions regarding that, let me know and we'll talk about it towards the end here. May go a little long today. I want to make sure we finish up this topic. Like 16 people in now, I got 9. Where does everyone go? I'm down to 8. I'm losing people rapidly. This is no good. All right, so we do have a lot to cover today, so I think I'm gonna go ahead and get started here. As always, if you have questions, post them up in the chat, post them up on the sticky board like you have done already, which I appreciate. Just remember, if you have any questions regarding the actual exam, don't put them on the sticky board after today, because I'm not going to go back and check that until we meet again in lecture. So just FYI on that point there. If you have any questions after the exam or after the lecture today, just email me. We can talk about it there. So the first one here is saying, would alprostadil, prostaglandin, and E1s be second-line therapy for erectile dysfunction after the patient has failed PDE therapy? Yes, that is correct. So if you had someone who could not tolerate PDEs for whatever reason, maybe they had side effects, maybe they have a need for nitrates or something like that, then yeah, you could use alprostadil. That would be a good option at that point there. Slide 19. It says phosphodiesterase inhibitors usually fail in patients due to food interactions. What type of food interactions would usually cause this type of failure? Thank you. Smiley face. This would be in the cases where like you could have delayed absorption. So for instance, if you were to have something like sildenafil with like a fatty meal, that could delay absorption. So again, you have to think about like the timing of these meds in terms of like how long they're acting, and then like if your onset's delayed and the patient's ready to have intercourse, then that could lead to a failure of therapy at that point. So, maybe having a light salad instead of, I don't know, a greasy cheeseburger could make a difference in terms of like the onset of action of something like sildenafil. So that's what I was referring to there. Someone says, in CKD related mineral and bone disorder, would dietary phosphate restriction be first line therapy, or would it be phosphate binders, or would you more than likely just use both together as an adjunct therapy? First line should always be non-pharmacologic means. So if you can get away with using phosphate restriction, that would be good. But recall they also do have, especially like they're on dialysis or something, they do have a higher protein need. So that can be a bit of a challenge in terms of getting the protein that they need, but also not getting a ton of phosphates. But if you can get rid of it in other places, like, the patient's not drinking a bunch of soda or something like that. The other thing is that if your phosphate's already high, then you probably want to go ahead and maybe tackle both of those modalities together. So use something like a calcium acetate plus phosphate restriction in the diet. So that would probably be you probably use both at the same time in a lot of cases, I would say. So only if the phosphate's high, though. Someone's saying for BPH in the 5-alpha reductase inhibitor section, when you say category X for pregnancy, does that mean the male shouldn't be taking it if they're sexually active, or is this more for female? Becomes pregnant, should they not be taking it? If so, when would a woman take a 5-alpha reductase inhibitor? Generally, they wouldn't. Not many indications, and I double checked online just to make sure that there's no issues with like a male taking it and having that effect to female. And it's like isotretinoin does that. So it's like if you have a male patient on isotretinoin for acne, you don't want them to be accidentally getting someone pregnant because could get some transfer. That's not the case from something like finasteride or dutasteride from what I've seen. The other thing, though, you want to consider is like, well, is a person of childbearing potential handling the medications? And that can be a problem. So, like, for instance, if we have, like, I can just think, at least in the pharmacy realm, if you have like a technician who's handling those medications, what happens if they accidentally handle some, a tablet gets crushed and then all of a sudden they're touching it and it's on their skin and they maybe, absorb a little bit of it or something like that. So it's not, that's why we use gloves and things like that to make sure we're protecting ourselves. And so you can see nurses being in that same position potentially. So it's not necessary that the patients would be taking it. So that's, again, it's just known to cause issues in terms of like developing, especially male fetuses. So that's why we want to make sure they avoid that. So, yep, that would be that. So I don't see any other questions. So let's go ahead and hit the ground running here with our talk of OB and gynecology. So, like I mentioned, the exam is going to be over sections 5 through 9, which I believe, where does that start out with? Where guys this stuff up? It's going to be neurology up through OB-GYN today. So that'll be all the stuff on your test for next week. So if you have questions, like I mentioned, either ask them today or just email me afterwards. We can talk about it there. And then I'll get your prescription assignment graded. Get you some feedback on that this week. So anyway, let's talk about first off, pregnancy and lactation. Basically, that's actually a good segue talking about 5-alpha reductase inhibitors in their pregnancy category. This is where we talk about that now. Basically, what we're talking about is teratogenesis, which is any sort of like, significant postnatal change that we're causing as a result of prenatal treatment. So if the mom takes something in utero or takes something while pregnant, that can then affect the fetus, and that can lead to things like congenital anomalies or malformations. It can lead to all sorts of things that we will see some pretty varied issues there. Just some examples of known teratogens that we've talked about previously. So things like ACE inhibitors are definitely a no-go for pregnant patients. Things like cocaine, warfarin. I mean, so lots of things on that list there that you certainly would want your patients to be avoiding. I think thalidomide is probably one of the most notable examples where it was something used for pregnancy-related nausea over in the UK for a period of time, and they actually found that babies would be born with their limbs malformed. They have these kind of flipper-like appendages, and so that's actually led to a lot of change in the laws in the US to make sure that drugs can show things like safety and efficacy prior to being put out on the market. So that's actually was a really big deal here. And so basically what we're going to see is that during fetal development, obviously, that's going to be broken up into, 38 to 40 weeks or so of gestation. That first trimester is really critical because that's when things like organogenesis are occurring here, as we have the initial organ development. And so this is the biggest place where drugs can be playing a role in terms of affecting that fetal development. And that's kind of a problem because a lot of times patients may not know right away when they're pregnant. It'd be nice if there's like a big light bulb that went off that says, hey, guess what, you're pregnant. You just had implantation of that embryo. That doesn't happen though. And so patients can be on these medications for weeks or months sometimes before they even realize that they're pregnant. And that's kind of the damage is already done at that point, which is why if they're on things like teratogenic meds, you want them to also be utilizing good, prophylaxis to make sure they don't become pregnant during that time. So we'll look at some options there. We'll talk about contraception a little bit later on. So how do we determine that something is teratogenic? Do we do randomized controlled trials and we have 100 women that are pregnant and we give 50 of them a medication and then 50 of them placebo and see who has birth defects? No, you can't do studies like that. It would be very unethical, as you might imagine. And so we have to base off of things like case control studies and case reports. I'm sure you're getting details on all kinds of statistical methods and study designs elsewhere in your curriculum. But basically, that's where we see a lot of this stuff. It's just sort of anecdotal information that we're gathering from women who just happen to have exposure during pregnancy and just seeing kind of what happens. So we're not giving it to them purposefully. It's just something to where the women happen to have been taking it, and then we can report on that. So things like voluntary reporting systems are really important and critical for determining what happens to women who take these during pregnancy. We also have animal studies that can be beneficial, but again, a mouse is not a person, a monkey is not a person, so it may not be always one-to-one, even though there can be some parallels there, because again, to some degree, mammals may act similar to one another, and so we do have some animal studies that can help us out from that standpoint, and that's something they would likely do during the clinical phase there, which is sad for the animals, I agree, but we can at least glean some useful information for us people. Basically, you're going to see that the old way to categorize these drugs is to use the A, B, C, D, X nomenclature. You're going to see that a lot of times we're moving away from that because the letters, they're only useful in certain cases, as we'll talk about. Either if it's a very clear-cut yes or no to use a drug, you're gonna find that a lot of drugs kind of fit in the middle somewhere where we don't have a ton of data. So I'll show you what that means in a moment. But basically, if something is a category A, that means it's super safe to use for pregnant patients. It is something that has failed to demonstrate risk to a fetus during the first trimester. We don't think there's any reasonable thought that it's going to cause issues for our patients now, right? So this is something, if my wife became pregnant again, which I hope does not happen anytime soon, because I love my 2 children I have right now just fine. That would be something to where I would feel very safe for her receiving a medication as category A. B is also very safe as well, but the evidence may not be quite as strong for its lack of harm that is shown. So this is either where maybe we have animal studies that indicate risk, but we have human data that says that it does not cause problems, or if we have both human and animal studies, just not as strong enough to make it something like a category A. Okay. Category D, I'll come back to C in a moment. Category D is something where we definitely know that there's risk to the fetus, but there may be certain situations where the benefits outweigh the risk. This is oftentimes if there's like a life or death situation for like the mom, where if you have maternal demise, then obviously you're going to have fetal demise. And so there would be very rare cases where you'd ever do this. And obviously, in most cases, there will be some sort of alternative that you could use instead. So that would not come up very often. And category X is like there's definite fetal risk. There's no way that there's going to be a situation where the benefits to the mom outweigh the risk to the fetus, and so it's absolutely contraindicated. So, for instance, if you have acne, okay, you can deal with the acne. It's not going to be there's no benefit there that outweighs the risk to the fetus that happens when you kind of mess up vitamin A synthesis for them. So that. With category C, though, it's kind of like a junk drawer where like everything kind of gets lumped into category C if you don't have enough evidence to really say if it's going to be a problem or not. So it's like, well, we don't know, so we're going to call it a category C. And guess where most drugs go? They go into category C. So it doesn't really do you a lot of good if you're a provider and you're trying to figure out what drug to give your patient. And it says, okay, I got 3 options and they're all C's. Which one's safe? That doesn't help you out at all, right? So this is why we're moving away from that and kind of changing the labeling up. And so instead of just giving you a very easy letter, which is, it's convenient. If you just have something that's just a letter, it tells you, yeah, if you're good to go or not. It's going to be more data driven. It's going to give you the results of studies and tell you things like, okay, well, does this cause risk to the fetus in terms of bleeding, or are there cases of things like, neurodevelopmental issues? Is ADHD more likely with exposure to this drug and things like that? It also includes information about lactation and then, issues in terms of reproductive issues that may pop up. So, is it going to cause, males or females become less fertile if they are taking this drug? So that's kind of the newer labeling that you'll see nowadays. And again, it requires you to do more reading, more critical evaluation of information. It's not as easy as just saying, okay, it's an A, I'm good to go, right? I can just use the drug. So it is what it is. However, when you're trying to select drugs in pregnancy, typically I just say avoid it whenever possible. If so, the safest drug to use for pregnant women is no drug at all, if you can. But you may have to consider if they have acute or chronic illnesses that come up during the pregnancy. Just because someone has hypertension and they become pregnant doesn't mean they all of a sudden don't have hypertension anymore. It just means they have both conditions going on. And so what we would like to do, especially if we have time, and if we have a patient who is trying to become pregnant but isn't pregnant yet, that's obviously the best time to strike before they're pregnant. We can identify the meds they're using, try to eliminate any non-essential meds, and then try to make sure that they are we impress upon them why it's important for them to tell us that they're going to take a med, because we can try to guide their selection or make sure they avoid anything that could be potentially dangerous. So discourage that self-medicating, and if we can, try to minimize the the duration or the exposure if we know there's a harmful medication they might need to take. So here are the different conditions we're going to talk about. I'm going to touch on some of the physiologic changes that happen during pregnancy, and then kind of touch on the meds that we're going to use in order to treat them, kind of what's safe and maybe what's not so safe here. So this will be kind of the first half of the lecture today. In terms of nausea and vomiting, this can happen for a variety of different reasons. There's a lot of physiologic changes that are occurring in women, and this can happen at any point throughout the pregnancy, but oftentimes it can be related to certain smells now being quite sensitive, or the patient becomes sensitive to certain smells that can trigger the nausea, vomiting. Also, if you think about later stages where you have this the baby that's pushing up on the diaphragm, that causes a lot of increased pressure, intra-abdominal pressure, and can lead to things like reflux and vomiting and things like that. So we're going to look at some things we can do to treat the more run-of-the-mill GI stuff that comes up for these pregnant patients. First off, with nausea, vomiting, if we can get around needing medications with dietary changes, so doing things like smaller meals, or if there's certain foods that trigger them, avoid those, things like that. However, in terms of medications we can use, actually there's a interesting combination of drugs you wouldn't necessarily think, but there's a combination of pyridoxine, which is just vitamin B6, plus an antihistamine, which is sold over the counter as Unisom, so it's actually used for over the counter sleep aid, called doxylamine. We know doxylamine, or we know anticholinergics, antihistamines can be used for nausea, vomiting, so that doesn't make that's not too big of a stretch of the imagination. But the pyridoxine is kind of odd, but we do see that it works, and so both of these are category A. Obviously, they need B vitamins. That's part of every essential development of a fetus. So that's actually not bad for them to get. And there's actually a combination product you can use called Diclegis, but oftentimes it's more expensive. So if you had someone where money was a problem, you could go ahead and just recommend over-the-counter pyridoxine and doxylamine together. Just buy that, and it's relatively cheap compared to getting a prescription-based product. So that's something to consider. Other drugs you can use include things like metoclopramide or promethazine. Just keep in mind that they can have some of that Parkinsonian sort of effects, kind of like what we talked about with antipsychotic drugs back in the behavioral section. And then your 5-HT3 antagonists like ondansetron, those are all very relatively safe as well, but they're going to be a little bit more expensive than something like promethazine. But keep in mind if the patient's still active and needing to go to work and things like that, what's the benefit of something like ondansetron over promethazine? Well, non-sedating, so that could be a really big benefit to your patients there. But if they're going to bed and they're nauseous and that's keeping them from sleeping, then maybe something that's more sedating is okay, and that's reasonable to use in those patients. So just something to consider. Again, you're going to find that it's probably more expensive than most of the other meds with the 5-HT3 antagonist, but it's relatively safe. We talked about GI already, so kind of disregard this point here. So we before we had this stuff rearranged a little bit, but just keep in mind that remember what you know about 5-HT3 antagonists from what we talked about before, because that still can apply here, right? So if there's any significant drug interactions or side effects, you'd want to know, again, how we're using it here in pregnant patients, and kind of add that to your knowledge base for the class of drugs there. In terms of heartburn, typically we, as I mentioned, smaller meals, more frequent meals can help out with this. You typically, if you're going to use a antacid, you want to avoid anything sodium containing. So like you probably don't want to use sodium bicarb because they can actually absorb that sodium, and that can worsen their blood pressure. And that's going to be a problem if they have preeclampsia, which we're going to talk about here in just a little bit. The other things you can use include things like sucralfate, which is carafate. Remember, has that kind of coating ability that neutralizes some stomach acid. And H2 antagonists can be really effective here as well. Obviously not ranitidine anymore. I forgot to remove that. But famotidine, Pepcid's totally fine. I'd probably avoid cimetidine due to CYP interactions, but Pepcid would be perfectly reasonable. And PPIs are very likely safe. It's just that they're newer, so you don't have as much evidence to say that absolutely there's no problems that can come about from this. But H2 blockers have been around for forever, and so we definitely know they're relatively safe. And again, that's one of the things that's really tough when you're talking to pregnant patients, because even if something has like a 0.01% chance of happening, if it happens to them, it's 100% risk, right? Because it happened to their kid. So this is why you'll see, and I term it mommy guilt. I'm sure other people have called it that too. But they can be very reticent to try and use medications because they're worried about anything that happens to their kid. It's their fault that it happened. So this is why educating them and talking about the actual risk and things like that can be really important. So you may have to do a little bit of convincing to say, listen, you're miserable right now. This drug is likely to not cause any problems. It's very safe to do that, right? Or I usually like to say like, hey, would I let my wife take this if she was pregnant? If I would, then yeah, I think it's pretty safe. I would let anyone else use that too. So that can be something you can use in your education. But anyway, in terms of constipation, again, when you're having, this is a pretty common thing you can see for some patients that are pregnant. Again, there's a lot of physiologic changes that are happening here. Again, you're having a lot of changes in the intra-abdominal cavity in terms of pressures and things like that, and things just kind of slow down. So and again, if you have a lot of constipation, you're more likely to develop hemorrhoids, which is certainly something we want to avoid. So we'll touch on that here in a moment. But in terms of constipation, making sure to increase fiber and water intake is the number one thing to do. And then sometimes some moderate exercise can be helpful to kind of get things moving along a little bit. Lissa's saying, sorry to go back. Do you ever see any site complications with 5-HT3 antagonists, or is that localized to serotonin in the gut? Yeah, it still works up in the brain, because it works on the chemoreceptor trigger zone, but because we're dealing with 5-HT3 receptors specifically, that doesn't really have any effects in terms of psych. It's a good thought, though. I like the way you're thinking there, but because it's specific for those receptors, you don't see any problem. So it's not like you're going to cause depression by giving someone on dancetrone. At least there's no evidence to suggest that so far. So, but yeah, it does work in the gut and up in the brain, but because it's specific, then that's why you don't see any issues there. Other things we can do include adding on things like non-absorbable fiber supplements, so things like Metamucil or your psyllium husk, things like that. And then in terms of actual medications, we can use things like stool softeners to kind of make it easier for things to pass. So things like Docusate can be very is usually relatively safe for patients. And nowadays we're starting to see a little bit more use of things like osmotic laxatives like Miralax. Since that's over the counter now and it doesn't get absorbed, that can be relatively safe, right? So if things don't get any systemic absorption, then it's probably good to use because it's unlikely to ever have any exposure to the fetus. And then stimulants we don't really use occasionally. I can't spell. Things like Cinna and Bisacodyl are totally fine to use here, but I'd say very limited cases. Don't use it too often. Again, they can become sort of dependent on that stimulant sort of action there. And if we can't avoid things like mineral oil because it can actually cause some issues in terms of fat soluble vitamin absorption. So things like A, D, E, and K. You definitely want to get those vitamins in because that's critical for development of a fetus. So that can be a problem. Moving on to pregnancy-induced hypertension, we're going to see here that this is basically any hypertension that either it was pre-existing or develops prior to 20 weeks of gestation. The reason why this is important is because if we let this kind of go on for too long, certainly you can see things like eclampsia, which can develop into seizures, can happen. That can be quite deadly to a patient. And you'll see this happens, with some regularity. So especially if they were hypertensive beforehand, this is certainly something that can exacerbate that. You can see here gestational hypertension, really anything over 140/90. And then we're also looking at things like the protein in the urine. If they start spilling protein in the urine, that's usually not a great sign because obviously you're not supposed to have protein in your urine in most cases. Severe preeclampsia is when they start to see again more protein. You start to see the blood pressure up like over 160 to over 110. You start to get things like visual disturbances and headache. Obviously if you start to have headache related hypertension or hypertension related headache, that's obviously not a great sign. And then they can develop that tonic-clonic seizures there. So we want to look at some ways we can try to help to prevent that. One thing can be things like activity restriction. So things like bed rest can be useful here. However, if you know anything about physiology that changes during pregnancy, you'll see that they actually become hypercoagulable. A lot of the increased estrogen leads to increased risk for things like VTE because it causes the liver to produce more clotting factors. The estrogen does. And so them being inactive can also increase the risk for VTE. So it's kind of a double-edged sword there. If you can do things like stress reduction and exercise, that can also be useful here. Some people find that calcium can actually help out with pregnancy-related hypertension, although remember calcium can be constipating. So if they have that as well, that can be a problem. And then actually the drug of choice if you have someone who is, say, in-house, like in the hospital setting, and was having preeclampsia or clamtic seizures, we actually use magnesium sulfate. And so they actually give, like, the biggest doses I've ever seen of magnesium given has been in OB-GYN, because of the fact that they're using things like 4 to 6 grams. If you think about a patient who's like coding, or if they're having, like, torsades or something, they get like a 2-gram dose of magnesium sulfate. These patients are getting like 4 to 6. And it kind of works as like a smooth muscle relaxant. So it kind of relaxes smooth muscle around those blood vessels and get your pressure down. So that is one thing there. If they are seizing due to their blood pressure, normal anti-epileptics are not going to work. You don't want to use things like benzos and phenytoin, because they can actually be tried on their own. And so really magnesium is the way to go there. So that's going to be if they're having like acute, preeclampsia. That's when they're in the hospital sort of setting. Obviously not going to give them IV magnesium out in their home. So for more chronic management of their hypertension, we have a couple of different options here. We used to use a drug called methyl-dopa as a drug of choice. And this is actually, it kind of works like a false neurotransmitter to activate alpha-2 receptors. And so this is kind of similar to how things like clonidine or guanfacine work there. Nowadays we use a lot more labetalol, which is kind of like a third-gen beta blocker we talked about previously, and it's also nice because it has some alpha blocking capability to kind of loosen up on those blood vessels there. I'm starting to see that used either for like chronic management orally, or it's also really good to use like an IV setting for sort of acute management of that blood pressure. Other things you can also use include our dihydropyridine calcium channel blockers, so things like nifedipine or amlodipine are used occasionally. And then for like really rapid IV treatment, you can use drugs like nitroprusside or nitroglycerin. Hopefully, things like your magnesium will be taken care of, things so you don't need to require, or you don't have to use things like nitroglycerin, but occasionally you can use that. In terms of gestational diabetes, this is, again, any diabetes that pops up during pregnancy. This is something where it's usually tested for at around 24 to 28 weeks. They'll do the oral glucose tolerance test, so OGTT, which by all accounts is pretty miserable. It's like you have to drink this like Gatorade stuff that is like just super sickeningly sweet. So it's pretty gross to most patients, and then you have to check their blood sugar at certain time frames to see, okay, well, are they able to process that glucose, or do they have some degree of insulin resistance leading to them having high blood glucose levels. You can also, look at things like A1C and fasting glucose, especially if they have pre-existing diabetes as well there. But the biggest thing for them is to try to modify their diet if you can, to try to maybe go low carb, something like that. Within reason, to try to get their blood sugars down. If they do have or do require medical treatment, then things like insulin are going to be a drug of choice. And we're going to talk about diabetes towards the end of the class here during this semester. So we'll talk a lot more about insulin then. But because it is natural, something that we produce, it's very safe for the fetus. It's also a big protein, so it doesn't cross the placenta to affect the fetus as well, which is a benefit. Occasionally we'll use things like glyburide, which is a sulfonylurea. It's a drug that causes the pancreas to release more insulin. It'd be one thing, and again, it could be relatively safe. And then drugs like metformin, which is an insulin sensitizer, also lacks teratogenicity, so they can be used sometimes if insulin's not a good option for your patient. Maybe they're deathly needle phobic and don't want to inject themselves or something like that. But we'll get into those drugs a lot more specifically when we talk about diabetes towards the end of the class. So another thing that patients at risk for, as I kind of alluded to, is the risk for thromboembolism. This is related, again, to the increase in estrogen levels that they develop as a result of being pregnant. And you find that increases the liver's production of clotting factors, so it puts them at bigger risk. Typically, we're going to see that we don't want to use warfarin for these patients because we know it's a known teratogen, so we certainly avoid that. And then for the most part, if they are, have evidence of VTE, or they have maybe they have like a congenital issue like a factor deficiency or something that leads them to be more at risk, this is where we can use things like enoxaparin or low molecular weight heparins here. We typically like that over something like unfractionated heparin because it has a longer half-life and they'll have to use it one time a day usually. And then if they had any evidence of VTE, then you go ahead and treat them for throughout the pregnancy, and then you usually do about 6 weeks after delivery. And by then, usually their estrogen levels are kind of dipping back down to normal. So you've kind of eliminated the risk, which is being pregnant, And then, then they're pretty much good to go at that point. Usually they'll get a total minimum of 3 months or so, depending on when they started taking it there. We have the newer oral anticoagulants, so I'm not sure if, that's going to change anytime soon. Again, when you have new drugs come out, you can't just give it to pregnant patients right away. You have to kind of wait and see what sort of evidence pops up in terms of its use. And so, maybe 5-10 years from now, it'll say, okay, well, Eliquis is the drug of choice for pregnancy-related thromboembolism. Certainly, that'd be better from a patient compliance standpoint because you don't have to inject it. But again, we'll see how that changes as time goes on. In terms of pain, typically acetaminophen is going to be your drug of choice here. It's a category B, relatively safe. Actually, my wife's sister is pregnant right now, so she was wondering about using acetaminophen. So we actually had to go through and look up all the data out there because she was, again, very worried about any kind of drug exposure. And so we looked up all the information. There's maybe some very weak links to things like, ADHD risk or something like that. But just remember, whenever you're looking up, and again, it's a bit of a tangent, but whenever you're looking up things like, risk factors or things like, risk ratios or hazard ratios and things like that, and it says, oh, this thing was associated with a risk ratio of 1.5, and it was significant, right? You always have to know what the baseline risk is. So if it's something is like, 1.5 risk ratio there, but your baseline risk was 1%, that means it goes to 1.5%, which is still very low risk, right? So sometimes you have to make sure that you are looking at the baseline risk there to make your assessments, and that can be really important because if someone just looks at that information, they may just say, well, look, there's an increased risk, I'm not going to use it. When in some cases it may be totally appropriate still, right? So again, being able to kind of look through the data, be able to interpret it for your patients is a very important skill, which I encourage you to take very seriously when you're out there and develop that skill by reading a lot of literature. Not everyone listens to me when I say that, but that's what I recommend. NSAIDs are typically safe to use during the first and second trimester, but there's sort of an issue that develops in the third trimester and I'm not sure what you've learned about fetal blood flow yet, but there is something called a ductus arteriosus, which is needed while the patient's in the womb because it allows for fetal blood flow to happen normally because those patients don't need their lungs because they're still in the uterus. If you close this too early, that can cause some circulatory issues for the fetus. That's normally something that closes after birth. But you can see that if you close that early, because you can reduce prostaglandin synthesis that normally keeps that open, that can be the issue here. So NSAIDs are actually category D in the third trimester. So I'd just say avoid it if they're more late stage pregnancy. You can actually use opioids. Perfectly safe to use, but we recommend really short courses because it can affect the fetus, and you can see cases where patients or infants will undergo withdrawal once they are born. So there's something called neonatal abstinence syndrome that can occur to fetuses who are exposed to opioids like throughout their pregnancy. They can be really challenging. Infants, actually, I had a couple of those I was dealing with just yesterday as I was working at the hospital. In terms of mental health during pregnancy, this is something that is, historically underappreciated, I think. Nowadays, we're starting to see more, recognition of, mental health issues that pop up either as a result of the pregnancy or maybe were, pre-existing that can maybe are exacerbated by the pregnancy. So things like anxiety, depression are probably much more common than what we actually think. And again, a lot of women will discontinue all their therapy due to the fetal concerns. But if you had depression, anxiety beforehand, and you stop taking your meds, it doesn't mean that just because you're pregnant, you get all these happy oxytocin, good feelings. It just means you're still depressed. You're just now off your meds, and so that can be a big challenge, especially when it comes to things like postpartum depression, where you can see things like suicide risk and things like that being quite dangerous. And again, you have to think about also the hormonal changes that are occurring in these patients, both during and after the pregnancy. It's certainly like a roller coaster in terms of the highs and lows that you hit there, which have a big effect on their mood as well, in addition to all the other stuff that can be going on with the patient. And so again, because we're recognizing it more, we're seeing more desire to being treated by physicians and PAs and everyone else in the healthcare field, which is good. In terms of treatment, SSRIs are typically the safest, as we know from just in general from our behavioral health talk. These are pretty effective, and we're seeing kind of the most evidence for use just because there are pregnant patients who happen to be taking this during that time, and then we can look at all the data and kind of collate that all together and say, okay, well, we didn't do a randomized controlled trial, but we have this many thousand women who are on SSRIs, and we saw these things that popped up, right? And so there could be some issues that do pop up. So things like risk for certain cardiac malformations. So with things like paroxetine, again, so that would probably one I'd avoid. But certainly agents like citalopram or fluoxetine are relatively safe there. Interestingly enough, you can see some withdrawal effects, just like we'd see in adult patients who kind of go off of their SSRIs cold turkey. You can see some issues with them. You can see the same thing in fetuses. I had one patient years ago in the NICU that we got called on for a tox consult because the kid was acting like, they're just kind of really unable to control their temperature, and they're just really fussy and wouldn't eat. And so it turns out that because the patient was born prematurely, they had to go to the NICU. They're separated from the mom, and the mom was basically giving them the SSRI that they were using. So we had to do some investigation to see what the mom was taking, and realize that they were now withdrawing from lack of SSRI. And so it's something we had to kind of treat through. So it's kind of interesting to see that, but it could be a risk. TCAs, we're going to have more side effects associated with that. It's more sedating, there's all the risk associated with TCAs, certainly. But they don't really know that they cause any kind of teratogenic effects. So they may be used as like a second line agent if the SSRIs are not tolerated, not effective, or whatever reason. Folic acid is another thing I just kind of throw in here at the end that's really important for patients to get in sufficient quantities. Honestly, the best time to supplement folic acid is prior to them even being pregnant, because folic acid is really important for developing the neural tube, and that's why you see neural tube defects being one of the biggest issues that happen with patients who are folic acid deficient. And so if we had good supplementation, either through diet or through prenatal vitamins or something like that, you could decrease the incidence of neural tube defects pretty significantly there. So 400 micrograms is usually recommended for prevention. And then if they have a patient who maybe has a prior history of an infant with a neural tube defect, they actually recommend like 4 milligrams if they want to get pregnant again. But again, a lot of women don't follow this recommendation. And again, if you're already pregnant, taking the folic acid then is kind of not going to do you any good from a neural tube defect standpoint. Certainly still good to get it in, but the best time is to do it beforehand. So if you have someone who is, trying to get pregnant, make sure they're getting their folic acid in at that point. So some other things that can happen during the pregnancy itself. So for patients who are having premature contractions, we can give them tocolytics, and this is basically things that try to stop uterine contractions and the cervical changes that occur normally when patients are getting closer to labor. So if you wanted to keep the baby in the mom for longer, you could use things like tocolytic therapy to stop premature contractions. And so a couple of things we have here can include some beta agonists. Again, these are all trying to decrease smooth muscle contraction of the uterus. If you can do that either through things like beta agonists like terbutaline, which is kind of similar to albuterol. It's just more specifically working systemically and can work on the uterus. Either this is given IV or PO. That can be useful to relax that smooth muscle, just like albuterol relaxes the respiratory smooth muscle. Magnesium is sometimes used occasionally, but more often than not, I see a lot of calcium channel blockers. So things like nifedipine. This is really good too if you have a patient who's hypertensive and they're having premature contractions. Something like nifedipine can be a really good option there. Sometimes they'll recommend NSAIDs like indomethacin, but this is more so to be used when patients have like a history of hypotension, and that might be a good option there because NSAIDs aren't really going to have a big effect on the blood pressure, as we know. Other things you can do too are the use of progesterone. We're going to get into estrogens and progesterone much more in detail here in just a little bit, but there is some thought that if you're giving progesterones exogenously, that can try to decrease contractions. I know I had a family member who had a history of a premature baby, so the next time they got pregnant, they actually got put on this progesterone here, just as an example to try to try to keep them in the. My family member actually had twins, and so it's kind of interesting because their first child was born I think like 33 weeks. Normally like 38 is considered term, and so they put her on hydroxyprogesterone here, this McKenna product, in order to try to prevent a premature labor for her twins that she got pregnant with the next time. And honestly, she ended up having the babies the same exact day gestational wise, so the same exact 33 weeks and whatever how many days. So it's pretty wild how still didn't really make a lot of difference here, but sometimes they'll try this. And so they'll do an IM shot weekly at around 16 to 36 weeks. They'll do it throughout that period there. And so again, this is more so if they have a high risk history of preterm birth. This is something they can try there. But they used to compound it like in specialty pharmacies, but nowadays there's a commercial product available. And of course, it gets a lot more expensive once the big drug company is making it, unfortunately. If you want to do the opposite and you wanted to induce labor, so maybe you're having someone who is in labor and you want to speed things up a little bit, there's a few things you can do. One is to help out with the actual development of the cervical changes there, the actual kind of changes of the cervix that allow for the labor to occur. And this can be done with prostaglandin analogs. So we can actually give things like dinoprostone or misoprostol, and this can actually help to develop ripen the cervix so that way it's ready for the baby to come through. And so we have things like Cervidil, which is dinoprostone. This is actually given vaginally and it's placed next to the fetus. I'm sorry, not next to the fetus, but next to the cervix. And so basically it sits there and it helps out with the development of the cervix, and then it's either there for 12 hours or once labor starts and then you remove it basically. This can cause bradycardia, so you do have to monitor fetal heart rate, which you'd likely be doing anyway throughout the labor. And then misoprostol can also be used. Remember, we talked about that drug before with its use for NSAIDs in order to prevent things like gastric ulcers from happening. But it itself can actually be used to terminate pregnancy by causing premature, labor to happen there. So it's called abortifacient if you're using it too early. But here you can use it for labor induction when the fetus is fully developed. Oxytocin is certainly more used, much more commonly in most cases. I know my wife got this twice for both of the pregnancies that she had, and so oxytocin is a natural hormone that we produce naturally. It is something it's called like the love hormones, like when you go and hug your cat or something like that, or your dog, or whatever your animal of choice is. You get a big dose of oxytocin, or if you hug your significant other, you get some oxytocin. It's a good feeling there. What's interesting is that in the uterus, you're going to find that it actually upregulates around the time of birth. It upregulates the oxytocin receptors there, and actually, once it gets activated by oxytocin, that actually facilitates more uterine contractions. So by giving it exogenously, you can kind of speed that process up and to cause more uterine contractions there. You can see some arrhythmias, so certainly you'd want to keep your patients on the monitor. And there are some small risks for things like bleeding due to afibrinogenemia that can happen there. So fortunately, it did not happen to my wife, but can happen rarely in some other cases there. All right, so that's it for pregnancy-related concerns. Again, if you guys have any questions, feel free to post them up. The second and third portions here of the lecture are going to be focusing on estrogen progestin specifically. So we're going to talk about things like hormone replacement, and then we're also going to talk about use of hormones for contraception purposes. So let's talk about the menstrual cycle briefly here. So basically, we've seen cycles like this before, either with the thyroid gland or other systems here, but basically the hypothalamus releases GnRH, which is gonadotropin releasing hormone. That stimulates the pituitary gland to release LH and FSH, and then that stimulates the ovary to produce things like estradiol and progesterone, which are our main sort of female hormones, so to speak. Now again, that's sort of a misnomer because again, guys produce estradiol too to some degree, even though it's just usually less for the most part. But we'll think about these as the feminine hormones for the most part. And again, these are going to be mostly what your typical female patients are producing through the ovaries here. So kind of what's happening during the menstrual cycle here. And again, this is the 28-day cycle. For some people it may be longer, some people may be a little bit shorter. This is typically what's happening. And you can see here that during this 28-day phase, you're going to find that the endometrium is getting prepared for conception and implantation of an embryo. And then you're also going to see a follicle developing during this period as well, with the culmination and having the release of a mature egg that can hopefully interact with the sperm, and then you can have actual conception occur. We will find different ways we can sort of throw a wrench in this system for our purposes in order to either prevent ovulation from happening, which is that release of the mature egg, or we'll just find some different things we can do here to try to change the system a little bit. But if you look at the hormone levels that occur here during this phase, you're going to find that during the first initial portions of kind of the first 2 weeks or so of the cycle here, your LH and FSH levels are kind of just, kind of going along, not doing much. And then all of a sudden around 2 weeks, when you have ovulation occur, you get this LH surge that happens here. And that's what's going to help to cause that developed follicle to release the egg for, and again, that's when ovulation occurs. That's when you're likely to have conception happen there. And you can see here during this phase 2, you're going to have a big bump in your estradiol levels, which will then dip down, kind of go down towards the 28th day. And then towards the end here, you're going to have progesterone that will also kind of peak up towards the later portions here. The reason why I show you this is because you're going to find that when we are replacing hormones that maybe these patients are missing, either due to menopause or something like that, we can try to mimic this ourselves. Or we can try to, if we're, say, for instance, trying to inhibit ovulation, we can also do the same thing and try to mimic this as well. So if you ever hear things like biphasic or triphasic oral contraceptives, this is what we're trying to mimic, is we're trying to mimic the different phases of the menstrual cycle here, which is why you'll see with like birth control packs, they may have different colored pills on different weeks because you're changing the doses of some of the estrogens and progestins here to try to mimic what normally happens. Now, of course, if no implantation occurs, there's no conception, then basically the endometrial tissue, kind of gets that signal of the progesterone and basically triggers off this sloughing of the endometrial tissue, and that's when you have the period actually occur there again, because it's just going to restart the cycle and get the uterus again ready for the next round, and hopefully it'll get pregnant in, right? That's what the body wants, or that's what it's trying to get primed for. But again, we can interact with the system pretty heavily here to try to prevent that from occurring. So we're going to talk all about our contraceptives here in just a little bit. Anyway, but a lot of times we may not be giving these drugs just to like prevent pregnancy, but we're helping out with the ovarian dysfunction that can occur here, and this is very common. We can either see issues in terms of like inflammation or neoplastic processes causing dysfunction of the ovaries, find uterine bleeding, things like that. You'll find that a lot of minor disturbances may be self-limited, especially if they're related to things like physical stress. I always think about the example of having like, for whatever reason, like this sticks in my mind, like cross-country runners, like in high school. So if you have like young women who are on the cross-country team and they're running like, dozens of miles a week, they're typically in the state where their body says, okay, we're pretty physically stressed here. There's no need to try to get pregnant right now. So they may be, they may have, a dysfunctional cycle compared to what the normal 28 days is because of that, extreme of diet or exercise. But then if they stop running as much, then things go back to normal. So sometimes it can be very dependent on the situation, which is why getting a good history from your patient is always important to see kind of what's going on with them. So in terms of estrogens, we're going to see that the main one that we produce is going to be estradiol. This is the major secretory product of the ovary. Whereas you can find some other ones that get formed in the periphery, things like estrone and estriol, but we'll focus mostly on estradiol. Interestingly enough, that other animals' estrogens can actually work for us as well. So if you ever see the drug Premarin, we used to get that from pregnant mares. So again, when you're pregnant, you see pretty big spikes in your estrogen levels, and so we used to be able to capture that in their urine and then purify it. And so it had two products called equilinin and equilin, and they actually could substitute for the estradiol that maybe a woman was not producing on her own, and then replace that as an example. And so the name Premarin stands for pregnant mare urine. Probably not something you wanted to tell your patients at the time, to be like, hey, this comes from horse pee. But nowadays we have synthetic ways of producing that, so that is no longer the case. If your patient asks if you're giving them horse pee to take, say no. That used to be the case, but not anymore. But pretty interesting whenever you have oddball sources for medications. Anyway, so what we can see here is that either during the follicular or the luteal phase that happens during that 28-day cycle, you're going to have precursor hormones that get produced here. So things like androstenedione, which is a precursor to testosterone. Either way, these two can be acted on by the enzyme aromatase. And again, you see a lot of interchange here between the different hormones. But the enzyme aromatase is going to convert this over into estradiol. Right. The biggest one we're going to focus on is this conversion of testosterone to estradiol itself, because again, that's where you get most of the estradiol, which is a major secretory product there of the ovary. And then they can go through other interchanges to turn into estrone or estriol there. But we're going to focus on estradiol for the most part. This will be important because if you have patients who are producing too much estradiol that maybe is causing issues in terms of like breast cancer, this is actually going to be a target here that we can try to inhibit the production of estradiol by inhibiting aromatase. And so you can kind of see already like what could be some of the side effects that happen as a result of that. Well, if you can't convert testosterone over into estradiol, then you have extra testosterone. So what might you imagine could happen to those patients? Well, maybe they can start to have masculinizing effects that can occur there. And so, again, you want to think about these side effects in terms of what are the hormone levels doing as a result of exposure to these various drugs here. So if you understand the mechanism, you can understand the side effects more easily. Now, we have a lot of different synthetic estrogen that we can provide to patients in order to get these similar effects. And so this includes things like ethinyl estradiol, this includes estradiol cypionate, valerate, as I mentioned, the conjugated estrogens that you can see here. They all work very similarly to one another. The dosing may look a lot different depending on which drugs you're looking at, but just know they can be dosed to have sort of equal potency there. And remember, when you're looking at the uses for these drugs, you want to think about, are we trying to replace what a patient's missing, like in the case of menopause, or are we trying to supply extra amounts of the hormones in order to shut down the that negative feedback loop? Because you're going to see if you're supplying extra estrogen and progesterone, that's going to then shut down the hypothalamus and the thalamus from releasing things like GnRH and LH and FSH. And that'll do things like inhibiting ovulation and whatnot, which we'll talk about here in a little bit. So in terms of the kinetics here, the big things to know are that the estrogens themselves get processed through the liver. And so they end up getting excreted a lot in the bile. And that's actually really interesting because they undergo something called enterohepatic recirculation, meaning they get excreted into the bile, into the GI tract. You will have colonic bacteria actually cleave those products. So they turn back into the regular estrogen, which you can then reabsorb. That's important because it helps to extend the half-life of estrogen, allow it to stick around for longer. That's important because if you have a disruption of that and you're not having reabsorption of that estrogen, the half-life goes down, levels of your hormones go down, and that could lead to things like having an accidental ovulation and pregnancy happen there. So we'll talk more about those cases in just a little bit. But we're also going to see, especially when you have oral estrogens being taken here, you see more hepatic effects that occur, and that can include a lot of side effects, things like risk for clotting, right? Because we know this estrogen can affect the liver in terms of producing more clotting factors there. I apologize if my green screen effect is getting a little annoying. I see it kind of flickering a little bit. I'm not sure really what to do to fix that. We're going to see, though, that in some ways that we can try to limit some of the systemic effects or the liver effects that we see from giving estrogen is by giving it via different routes that act more locally. So either by giving it via injection or transdermally, you kind of skip that first pass effect when it goes to the liver, or just by, if you're only having vaginal effects, just place it in the vagina, and then you're going to see local effects there that sort of limit a lot of the systemic issues. So dosage form is going to be really important here, as we'll see in just a little bit. So what do the estrogens actually do once they are in the cells? They're going to get down to the side of the nucleus just like any other hormone and affect things like gene transcription, protein production, etc. And again, depending on the type of tissue you're dealing with, you're going to get different effects, right? So if you were to go down to the estrogen receptors in the breast tissue, this is going to cause breast development, right? Breast enlargement. If you do this down in the bones, this is going to cause decreased osteoclast activity and lead to stronger, healthier bones, right? Because we know osteoporosis is a big risk for older patients that are developing menopause, right? So the mechanism is the same. It's just you might find different response elements at the actual different tissues, and that can cause different effects here. So what sort of clinical effects are we talking about? Certainly female growth and sexual maturation, so things like development of the sex organs. You can see things like closure of the growth plates on the bones, which is kind of interesting because you always think about female patients having kind of their growth spurts early in like places like middle school. They get really tall all of a sudden, but then they generally sort of peak out and are generally shorter than male patients because the estrogen is causing their bones to sort of close up, and at that point they don't really get any taller at that point. On average, generally speaking, but certainly there's some exceptions to that. And then you'll see things like body fat distribution, hair growth, or as a result of production of more estrogen there. You'll also see the estrogens help out with endometrial lining development, which is important if you're, the body's trying to get ready for pregnancy to occur there. But again, when you have that interaction with progesterone, remember you see the progesterone sort of peak up towards the latter portion of the cycle. You're going to see that encourages the normal regular bleeding and shedding of the endometrial lining if pregnancy has not occurred there. You will find though that if you just have unopposed estrogen effects, so you just have estrogen being given by itself with no progesterone, you're going to see hyperplasia of the endometrial tissue. You can see a lot of abnormal bleeding because like all that tissue just keeps developing and then just kind of has no need, it just kind of sloughs off. And that kind of unabated growth can also lead to things like cancer risk. So we're going to see here that if you have unopposed estrogen effects in the uterus, you're going to find that endometrial cancer risk is on the list of things you want to think about. We're also going to see other metabolic effects, things like development of skin and blood vessels, things like decreased bone resorption. So remember that elderly patients, osteoporosis is a risk a lot of times because they don't have enough estrogen around. You also find estrogen helps to antagonize the parathyroid hormone effects. You'll find having effects on the clotting factors, as I mentioned before, and also some effects in terms of things like your lipids and whatnot. So things like increasing HDL, decreasing certain other cholesterol particles, things like that. So the coagulation effects are really important here. Notice they increase a lot of those vitamin K dependent clotting factors, things like 2, 7, 9, and 10. They also decrease the activity of antithrombin 3. So this is why, especially when you have like younger patients who are taking estrogens, anytime you have like, a younger female patient coming in for chest pain, you always want to ask, hey, are they taking any kind of estrogen-based products? Because frequently that's a cause for that. Other things you're going to find too, they can affect mood and libido. And you'll also find that estrogens themselves don't just interact with estrogen receptors. Sometimes they can interact with some of our mineralocorticoid receptors, things like aldosterone receptors. And that can lead to things like fluid retention and edema, which is why you'll see that certain females during their cycle, they can kind of get more puffy or they put on a little bit of weight. Some of it is related to these estrogen effects that are causing some of that fluid retention. So where do we use estrogens? Like what kind of things do we use them for? So first off, they have primary hypogonadism. So maybe they had like a pituitary tumor and it was removed and all of a sudden they can't produce any LH and FSH on their own now. We can replace that and give them exogenous estrogen here to try to mimic what they would normally get. So for instance, you could start them off at 11 to 13 years of age when normally puberty would sort of kick in, and then try to mimic that, what their normal cycle would look like. And then you can add a progesterone, which we'll talk more about later, once they have their first period, basically. Sort of showing that they're having that normal development of the uterus there. And again, this is to help out with their bones. It helps out with the development of their secondary sex characteristics, all those things there. So that could be one reason. One thing we'll see a lot is what we call HRT, which is hormone replacement therapy. Basically for postmenopausal women, you're going to see a lot of like very typical symptoms here. Things like loss of periods. They're going to have these vasomotor symptoms where they get those hot flashes that occur there. They can also develop genital atrophy because the estrogen isn't there to sort of stimulate growth of the tissue. And that can lead to a lot of things like dyspareunia or like painful sex. They can have a lot of itching, things like that. So vaginal symptoms could be a big reason why one needs estrogens. You'll also see kind of accelerated bone loss and change in lipids. It may increase our risk for things like atherosclerosis and secondary cardiac effects there. Interestingly, though, you don't want to give estrogens for their cardioprotective effects, mainly because there is increased risk of certain things like cardiovascular issues, mainly due to the clotting factors being upregulated and breast cancer risk. So typically, you're not going to give estrogens to protect the heart. You're going to be using it for some of these other things here that may be developing. So what we're going to find is that for postmenopausal hormonal therapy, the HRT, we have to take into account all their risk factors. So things like, are they high cardiovascular risk? Are they have a risk for breast cancer, endometrial cancer, all those sorts of things there. And you're going to find that by using non-oral routes, you can help to mitigate some of these risks here. So again, when you give things orally, it's going to go through the liver first, and that's where you see most of those liver effects sort of predominate. So if you can do things like transdermal or vaginal estrogens, you can help to mitigate some of those issues there. And you want to use a low dose as possible in order to help manage those symptoms. So if it's mainly just hot flashes they're having, then use the lowest dose needed to treat that. If they're having vaginal dryness and dyspareunia, then maybe just use a vaginal product and use the lowest dose you can there, right? Now, patients who have had a hysterectomy, they no longer have a uterus, they don't have any endometrial tissue left to stimulate, they can receive estrogens by themselves. That's no problem there because their endometrial cancer risk is basically zero. If they do have a uterus still intact, you want to decrease that endometrial hyperplasia and cancer risk by giving that along with the progestin. If they still have an intact uterus, they need a progestin on board as well. You don't want to give those patients just estrogen alone because you increase the risk for a lot of like abnormal bleeding, and then their cancer risk is higher as well. In terms of osteoporosis prevention, we've talked about this previously when we were talking about some more room topics. And so remember that it's important they keep their vitamin D and calcium levels sufficient, making sure they're getting some exercise, maybe doing some water aerobics or something. And again, you're going to find the people who are at highest risk for this are going to typically be those thin Caucasian smokers who are fairly inactive. They have low calcium intake. That's kind of like just a perfect storm for having vertebral or femur fracture or something like that. And then for if they're having just atrophic vaginitis alone, that's where you can use topical preparations. When I say topical there, I basically mean not transdermal necessarily. What I'm talking about more is like vaginally administered hormones. So like creams and gels and things like that can be inserted intravaginally in order to treat those specific symptoms. So again, custom tailor the dosage form based off your patient. I'll just give you some examples of this in just a little bit of the various dosage forms and how we use these drugs. Other things we can use them for is also for ovulation suppression. So if you have patients who have like really intractable dysmenorrhea, I actually just used just the other day when I was working, we had a patient who had very severe uterine bleeding as a result of her periods. She actually required a blood transfusion, and so we actually used estrogen in order to suppress this because it was basically her LH and FSH was stimulating her ovary to produce this estrogen. And so if we can try to shut that down, we can actually give estrogens to shut that whole development process down in order to decrease the bleeding there. So sometimes you'll see use for that. And then, as I mentioned, we can also use it if patients have sort of excessive androgen secretion as a result of LH and FSH. You can actually give this to shut down that negative feedback loop, or to activate the negative feedback loop, I should say. That will actually decrease androgen production for them as well, right? Because again, if your body's producing a lot of estrogen, it has to do that by first producing androgens and then use that enzyme aromatase. So if you can kind of shut down that androgen production, it can help out with things like amenorrhea or hirsutism. You may see that sometimes in patients who are having like PCOS and things like that. So adverse effects of estrogen, certainly they have their problems. Uterine bleeding is going to be one of the big things you're going to see here. And again, you always want to make sure that if a patient has abnormal uterine bleeding, you always want to rule out the scary stuff first before you give them any kind of hormones. So make sure they don't have like endometrial cancer beforehand. In order to prevent this uterine bleeding, you want to use the smallest dose of estrogen possible. And then we can also give them the drug cyclically to try to mimic sort of that normal withdrawal bleeding period, right? And so we're going to talk about estrogens and how long to give them for and withdrawal periods and things like that. You don't necessarily need a withdrawal period from estrogens. If the patient's not having any issues, you don't need it. So some people can be on their HRT and they're just on the same dose of estrogen every single day for forever, basically. And again, to help out with the endometrial hyperplasia, we can give it co-administration with a progestin. So we'll look at some different drug products and how we use those in just a little bit here. Cancer risk is a big thing to consider too. So things like breast cancer risk is certainly something we want to consider if they have a high risk history in their family, for instance. Endometrial carcinoma, as I mentioned, can be mitigated by using something like a progestin there. And then, interestingly enough, there's a product called diethylstilbestrol, which was used for certain women for birth control purposes. I'm trying to remember what they're using it for specific. It's been off the market for so long, but basically is actually causing the mothers were using it, and then it actually caused cancer in their offspring, which is really kind of interesting. But yeah, that drug has certainly been off the market for quite some time now. So we'll look at some different drug products and how we can sort of get around this. Other things you're going to expect to see can include things like nausea, vomiting, breast tenderness, hyperpigmentation. Again, different tissues are going to respond differently to estrogen. Some people, their migraines may be worsened, which is kind of interesting because for some people, giving estrogens actually helps for migraines. It can just depend. Cholestasis, this is going to be more so seen with the oral products, as you might imagine, because they're going to have a lot more first pass effect. And then, blood pressure can increase a little bit. But again, it has to do mainly with those mineralocorticoid effects causing fluid retention and whatnot. And so by using the lowest dose possible, you can help to sort of get around this. So what are our contraindications to using estrogens? Any sort of estrogen-dependent neoplasm, any undiagnosed genital bleeding, liver disease, thromboembolic disorders, and heavy smokers, all of that can increase their risk for a lot of the problems we've been talking about so far. So again, if they're a smoker and they have a thromboembolic disorder and then you give them an estrogen, the risk for having a PE or VTE is going to be a lot higher than if they did not have those risk factors there. With progesterone is really the most important one that we're going to see in humans. Again, it's a precursor to a lot of hormones, things like estrogens, androgens, and our adrenocortical steroids. And we're actually going to see here that progestins, the ones that we give, the synthetic ones, are going to have a lot of variability in terms of their activity at the androgen receptor, the mineralocorticoid receptor, estrogen receptor. So that would be important when we're looking at side effect profiles for these. And again, how you select the, say, for instance, birth control product you select for your patient may be dependent on the type of progestin that you want to give them, which I'll show you some examples of here in just a little bit. So as I mentioned, some of the historical problems have to do with these variable effects at the different receptors. So when I say AR here, this means androgen receptor. When I say MR here, that means mineralocorticoid receptor. So if you activate androgen receptors, that's going to cause more masculinizing effects. So it can cause hirsutism, can cause some voice deepening, things like that, which are generally considered to be not good side effects for the most part, for female patients at least, typically. And then the mineralocorticoid effects are what's going to cause things like fluid retention, increase in blood pressure, edema, things like that. So, for instance, looking at things like norgestrel has high androgen receptor activity, right? So it may lead to a lot of the side effects that women just don't want to have, for instance. Levonorgestrel as well. When you start to get down into some of the newer ones, so for instance, like drospirenone actually has anti-mineralocorticoid receptors, so you can actually see a little bit of weight loss with this one because you're having some diuretic effect and anti-androgen receptor activity. So it helps out with things like, if they had hirsutism beforehand, this can actually help out with that potentially. So I do see a lot of female patients do like things like drospirenone for their birth control, for instance, because they do get kind of mitigate some of those side effects there. But again, everyone's a little bit different in terms of how they're responding to it, which is why when you look at the list of all the birth controls that are available, there's like a gazillion and a half of them because of just the different ways you can dose it, the different progestins that you can include, and everyone responds a little differently. So if they have a bad time with norgestrel, try something like norethindrone and see how they respond to that in those cases, just as an example. These don't really have the same progestins on the same liver effects as you're going to see with the estrogens. They mainly just kind of get excreted through the urine. Not a lot of pharmacokinetic issues to speak of for them. So from that standpoint, they're pretty safe, are pretty simple. These are mainly going to be used for hormone replacement therapy for patients, especially if they still have an intact uterus, or we can use it for long-term ovarian suppression. So we're going to see that when you're trying to suppress ovulation from occurring, or for maybe dysmenorrhea or something like that, you can utilize estrogens plus progestins or progestins by themselves. Again, you never want to give someone with an intact uterus an estrogen by itself because it's going to lead to the cancer risk and things like that. So when you hear about things like the depot shot, this is what we're talking about. It's just a progestin by itself. So here we have one example, medroxyprogesterone acetate, which is an IM shot that is given every 90 days. So basically, once the patient has that, they're pretty much protected from an ovulation standpoint for that 90 days there. Some of the issues you'll see, though, with using progestins by themselves is they can cause prolonged anovulation and amenorrhea. And this is probably not the thing you want to use when patients have a time frame of when they want to get pregnant, for instance. So as an example, if you were kind of getting into PA school and you're like, okay, I don't want to get pregnant during PA school, but afterwards I'm going to marry my sweetheart and then we're going to get pregnant, right? That's not everyone's track in life, but if you want to do that, this may not be a good option because this can lead to that prolonged anovulation. It takes time. It's not like, the second 90 days is up, that drug's out of the system. It has a tail on it. and can take it some time to get out of the system there. So not good for near future pregnancies if that is something your patient is interested in. And again, this is more of a problem with using progestins by themselves. We'll get more into that a little bit later on. But these are good if you have a patient who has dysmenorrhea, endometriosis, or something, and they cannot receive an estrogen. This is a good option for those patients there. In terms of adverse effects, you may see a little bit of increase in blood pressure, mainly due to the mineralocorticoid effects. And again, looking at the androgenic activity, you can see some lowering of the HDL. So again, you want to watch their lipid profiles when you're administering these drugs or making any big changes, for instance. So let's talk about specifically hormone replacement therapy. So again, this is going to be for patients who are maybe not producing their own estrogens and progestin anymore due to menopause, due to their just getting older there. And so this is something that has an FDA approval for. Basically, you're treating the symptoms associated with menopause, so things like the vasomotor symptoms, like the hot flashes. You're using it to treat things like the vulvar or vaginal atrophy that can happen here, causing things like dyspareunia and dryness and irritation. And then also for prevention of menopause or osteoporosis, basically. So these are the main things that we're using HRT for. Again, if they're not really at risk for any of these, then you don't need it at that point, right? So it's not like just because your ovaries are not producing estrogen anymore doesn't mean you have to replace it immediately. It's really just for those particular symptoms. Because again, there are risks for giving these hormones here. They're not completely benign. So typically, if they still have an intact uterus, then we're going to go ahead and use estrogen plus progestin therapy. And so you could just do the same dose of estrogen and progestin every single day, no problem. There's no need for a withdrawal period here. There's no issues there because the progestin is keeping the uterine tissue intact and keeping it from getting too out of control in terms of growth, which is what the estrogen is promoting, right? So they kind of antagonize each other from that standpoint. Sometimes you'll see they will try to mimic the normal cycle. So for instance, you may find that they will give a product that has estrogen on days 1 through 25, days 10 through 14, they'll include a progestin, and then maybe they have a drug-free period at the end. That's if the patient prefers that, if they want to have a withdrawal bleeding period to kind of mimic what they naturally had beforehand, that's fine, And we'll look at some of the different products here that are available to us and see some of the different ways we can do that. If a patient has a history of a hysterectomy, then they can get just estrogen by itself, either continuously or cyclically, so you can still have that withdrawal bleeding if they want. And you'll typically see that, again, we're just replacing what they're missing. So you could use like a low-dose oral contraceptive, but oftentimes those products are trying to like shut down that whole negative feedback loop. And so it's usually a lot more estrogen effect than what you need for just replacement. So you could use low-dose oral contraceptives, but it's generally not preferred. We'll just use specifically ones for HRT. In terms of different dosage forms, we're going to see oral is going to be more likely to undergo that first pass because, again, it has to go through the liver to get absorbed. And that's going to stimulate this hepatic protein. So that risk for things like, clots is going to be higher with that. Transdermal products are going to be better for patients who have like a history of hypertension, lipid issues, risk for VTE, cholelithiasis, all of that, because transdermally that really skips the liver in that first pass effect there and helps to mitigate that. And then intravaginal is really preferred if they only have vaginal symptoms. So if they're not having, hot flashes, but they're having, excessive vaginal dryness, then this is a good product for them. You can use things like gels or creams or things like that that can be inserted vaginally. Also, to help out with limiting the vaginal absorptions, that way actually limit some of the other systemic effects. You see less risk for some of these other problems. You can actually use things like vaginal tablets or vaginal rings that have the drug sort of implanted into it that slowly release over time. So again, you'll still see the vagina is highly vascular. You're going to see some absorption of the stuff there, but there's some ways you can mitigate that with the dosage form. So just give you some examples of what this would look like. Here's an example of a conjugated estrogen vaginal cream. And so basically you'd place a certain amount of cream in here depending on the dose that they need. This would be the applicator, and then basically they insert this intravaginally and then depress the plunger, and then that would allow for the cream to come out, and it can be just stay right there in the vagina itself. Yeah, so if they're not having hot flashes, you would use intravaginal. Yeah, if they're just having vaginal symptoms, then that's what I would probably go with. You may still see some benefits systemically if you use something like, like a primer and cream, for instance. But the main purpose of using intravaginal products is just to get local vaginal effects because, again, once they've lost that estrogen, they're not having stimulation of that tissue, which is why you can see things like the vaginal dryness and whatnot. Here's an example of the E string, which is basically placed just right up next to the cervix, and they can just stay there for a certain number of days, and then they'll go back and replace it when need be. I don't remember how many days this one is specifically. It's probably either 30 or 90 if I had to guess. And again, if they're having side effects from it, they don't like it, they can just take it out and then they have no more exposure, right? So there's some benefits from that standpoint. Just make sure when you're educating patients to make sure they know to like clean their products effectively. So like this applicator here, if they're going to reuse it, make sure they clean it off so that way they don't have like a risk for, vaginal infections or something like that, right? Okay, then switching gears and talking about oral contraceptives and how we can use them. Again, this is basically using a combination of estrogens and progestins. Again, if they're being used for contraception, it's implied that your patient still has an intact uterus, right? So this is why you can use a combo of estrogen and progestins. And we'll see that they can be formulated in a lot of different ways. So for instance, there's monophasic, meaning you get a constant dose of both estrogen and progestin throughout the menstrual cycle. There's biphasic, which means you may have, there's one point during the month where you're going to have a switch in terms of the doses. So probably like the estrogen may change the dose or the progestin may change the dose. Or there's triphasic. So if you hear of drugs called like orthotricycline, for instance, that means it's triphasic. And you'll have two switches. And again, the more changes you have here, the more closely similar to the normal menstrual cycle that the drug is achieving, which may be good for some patients. It may help to mitigate some of the side effects we're going to see here. So you either are going to use that combo for contraception purposes, or you can use a continuous progestin only. We'll see there's some pros and cons to doing that here in just a little bit. It's probably not going to be suitable for a lot of patients, but again, how are these working? These are basically shutting down production of GnRH and LH and FSH to a big degree, right? So if you don't have LH and FSH because the pituitary gland says, okay, well, I'm not producing, I have all this extra estrogen and progesterone around, I don't need to produce LH and FSH, the levels are high enough already, that will then not stimulate the follicle to develop a mature egg, right? So that's why you get the ovulation inhibition here, the ovulation suppression, because you just don't have the LH and FSH available in order to help stimulate that process there. So that's one reason why you might do that. Other things, effects you can see here as well, is it also helps out with kind of producing an environment that's not really hospitable to a sperm to cause implantation to occur. You'll see things like changes in cervical mucus. You'll see some changes to things like motility and secretion from the uterine tubes. And basically, it just makes it so it's unlikely for conception and implantation to happen. Now, are these foolproof? Are they perfect? Absolutely not, right? We're going to see there's some issues here. But we will find with progestins by themselves, they don't always inhibit ovulation. They don't have as strong of an effect on the pituitary to shut down production of LH and FSH, but they still make for an hospitable environment for implantation to happen. So again, they can still help out from a contraception sort of purpose here. What effects we're going to see? Again, you're going to find the ovaries are going to be smaller because they're not being stimulated, which could be good for things like endometriosis, or if you have, PCOS or something like that. You will find that most women will return to normal menstrual patterns once discontinued. So a lot of people will go right back to ovulating normally once they stop taking the drug. And again, this is if you're taking the combo therapy of estrogen and progestin. Some people may remain amenorrheic for a long time, but that's not the usual case there. Again, in the uterus itself, some of the things you're going to see is going to be hypertrophy and sometimes polyp formation, but also going to get thicker, less copious mucus happening. And again, that makes it more difficult for things like sperm to travel in order to cause conception to occur. In terms of breast effects, you're going to certainly see enlargement because you're going to have those estrogens affecting the breast tissue, causing increased growth there. And it will also suppress lactation. And then from a hematologic standpoint, we will see, and again, most of these products are used orally. You will see things like increases in clotting factors, decreased antithrombin 3 activity. So, of course, the risk for VTE and PE are going to be a lot higher for those patients. The risk is higher while they're taking it. As soon as they're off of it, though, it kind of goes back down to baseline. You can see some hyperpigmentation, and in some cases, you will find androgen effects from the progestin can actually lead to worsening acne. This is kind of hit or miss because some patients will find their acne improves with use of oral contraceptives, for some it can worsen. It frequently has to do with what the progestin is that they're using and if it has more or less androgen activity. If it has more androgen activity, you're more likely to see more of these testosterone effects. You're more likely to see things like acne develop here. How we're using them, again, this is going to be for contraceptive purposes, I think most classically, although certainly we know there's other uses for them. But if you're looking at, if you had perfect use of these contraceptives, you would find that there would only be between, which I think is funny to think of, half of pregnancy, but if you were to follow, 100 women for 1 year, there would be between half and one pregnancy on average. What actually happens is probably closer to like 5 to 12. So again, if you follow 100 women for 1 year on these products here, you may have like 5 to 12 failures. That sounds bad, but that's mostly because of the human element here and due to improper use of the medications, or they forget to take doses and things like that. So there's nothing perfect. But again, the more perfect they can be in terms of taking their meds, the more likely it is to be effective. You're also going to find there could be a lot of drug interactions that could be a problem here. So if they have like a enzyme inducer like phenytoin on board, that can ramp up metabolism of the estrogen and lead to lower levels. So you don't get as good of suppression of ovulation, then you can get pregnant. Or things that inhibit the enterohepatic recycling, which is why if you ever hear, oh, if you're on antibiotics, you should use a backup form of contraception because it could disrupt that enterohepatic recycling and lead to lower estrogen levels. Again, there's nothing concrete that says that absolutely is going to occur. But again, if you're thinking about recommendations to your patients, it's probably not going to hurt if they use a backup form of contraception while they're on antibiotics, right? Probably not feeling too good. They probably don't want to have sex anyway, but you never know. Other causes or other reasons why to use hormonal contraception is going to be for endometriosis. So you may find that patients can use estrogen alone, may be sufficient, but again, if they still have that intact uterus, you have to add a progesterone to keep the growth from being too much there. And again, to use the lowest dose possible help to limit the adverse effects. And again, this is due to your decreasing production of LH and FSH by supplying estrogen that shuts or causes that negative feedback loop to go into effect there, right? In terms of adverse effects, kind of the mild things you might think about include things like nausea, mastalgia, breakthrough bleeding. Again, this is frequently caused by either too much estrogen, which can be alleviated by using maybe smaller doses, or if you have progestins with more androgenic effects, this helps to limit some of that. Headache, for some people, migraine might be worse. Some people, their migraines might improve. It just depends. Certainly, there may be a small risk in increase in CVAs, cerebrovascular accidents, due to the thromboembolic effects. So certainly something to consider there. But certainly, if they have migraines that coincide with therapy when they start it, then I'd probably avoid it at that point there. And then there could be some cases where we have withdrawal bleeding that fails to occur, and this can be kind of distressing to the patient because they might think that they're pregnant. So if they do have that, again, and frequently, like when you trial out a new birth control, you give them 3 months worth in order to see kind of how they're going to respond to it, because a lot of these side effects that happen early may improve as time goes on. So by the time, something that happened during the first month, they had failure of withdrawal bleeding, by the second or third month, it happens normally. So it really just depends on the product there, and you give them a little bit of a trial. Other things we can see include some breakthrough bleeding. This is much more likely with the progestin-only products there, so that could be, mildly, kind of distressing to the patient there. And certainly you're going to see this in more low-dose sort of products. For some people, they like to use the bi and triphasic products because it overall it works on some of this breakthrough bleeding without increasing the total amount of hormone they're having to take. So we'll talk about that a little bit later in terms of like if something is likely due to an estrogen problem, or a lot of it has to do with when the bleeding is occurring during the cycle. So I'll talk about that later. You're going to find weight gains are going to be a little bit more common with androgen-like progestins. Also, if you have things that have high mineralocorticoid activity, that's also going to cause some fluid retention. So you may want to shift to a product with a different progestin sort of effects, either less androgen effects, less mineralocorticoid effects, or sometimes dieting can help out with this too. So it just depends on the patient. As I mentioned, you'll see that increased pigmentation, especially in women who have like more dark skin to begin with. And you'll see that it can be reversible, but it's slow going, so it can be something to see there. And as I mentioned, with the acne is more so related to the progestins that are more androgen-like. And again, for some people, you actually find that estrogens improve their acne. So really, again, it's very dependent on the patient. You'll see that everyone responds a little bit differently. With the hirsutism, that's typically aggravated by androgenic progestin. So again, if you can switch them to something less androgenic, that's good. And you can see some issues in terms of uteral dilation. This is kind of similar to what you might actually see in pregnancy, because again, we are giving sort of super therapeutic doses of estrogen to shut down ovulation. So things like bacteriuria might be a little bit more frequent. So UTIs might be a little bit more likely there. To go along with that, vaginal infections may be a little bit more common as well. And then in terms of amenorrhea, this is probably more likely to occur in people who had like menstrual irregularities beforehand. It may be related to things like prolactinomas and things like that. So, maybe due to some pre-existing issues the patient had beforehand. Severe issues here include VTE that can happen. Again, your risk is about threefold higher than when on low dose or contraceptives by themselves. And so you're going to see here that this is going to happen during the first month they're on it and will stay consistent until they're off of the drug there. And again, the risk goes down to about normal as soon as they're off of it for about a month or so. The biggest thing here you're going to see is if they're smoking along with taking these, if they are, if they had hypercoagulability issues beforehand. This is related to the estrogen only. So the progesterone really doesn't have any effect here whatsoever. This is only related to the estrogen. Other things we can see to go along with that include MI, PEs, I was mentioning before. This is certainly a bigger risk for patients who have a history of like obesity, hypertension, etc. Certainly smoking can see this as well. A lot of this may be related to things like, the androgenic progestins lowering our HDL levels, right? So that can increase our risk for things like atherosclerosis. And some of these patients may be on these for many years, so you can see some of these more chronic effects that can happen here. As I mentioned, CVA, especially in women who are over 35. And from a gastrointestinal standpoint, things like jaundice can happen here. This is probably going to be seen within the first 3 cycles or so. So again, that's why you give them 3 months to trial it. And usually responds with discontinuation of the drug within a few weeks or so. Other things may include depression. Again, for some people, you'll find that depression has helped with this. Some people, you'll find that it's worsened. You just have to try different ones to see how they respond to it. And then the risk for cancer. You're going to see here that if you're using an estrogen progestin combo, the risk for endometrial and ovarian cancer is going to be actually reduced. And we see that lifetime risk of breast cancer tends to be unaffected here. But cervical cancer risk may be increased if they have women who have HPV concomitantly. So that's one thing to consider there, but usually not the biggest concern out of the bunch of these for sure. So this is a good table to look at to compare the different types of progestins together to see whether they're getting a lot of androgenic effects or progesterol effects. Again, that can kind of lead you to pick one versus another in terms of side effect profiles. Again, I see a lot of people do like Progesterone quite a bit because it has basically negative androgenic effects. You're going to see really no mineralocorticoid effects, so some people do respond pretty well to that. It's like Yasmin and products like that. So in terms of contraindications for use of hormonal contraception here, if they have a history of thrombophlebitis, cardiovascular issues, cerebrovascular disorders, or any sort of like unknown cause for vaginal bleeding, you always have to rule out tumors and things like that. If they are an adolescent that hasn't undergone the epiphyseal closure, that can close that early. It may lead to growth stunting in some cases. And then be really careful if patients have hepatic enzyme inducers. So if that's something like rifampin or phenytoin on board, that can lead to lower estrogen levels, and maybe you don't get as good a suppression of the ovaries, and less ovulation can happen there. They're on antibacterials, sort of a theoretical risk, but it interrupts that enterohepatic recycling. Look at some ways we can get around that a little bit later. And then obviously if they're pregnant, you don't want them to be taking contraception because obviously it's kind of a moot point already. In terms of progestin-only contraception here, this is good for patients who you don't want to give estrogens to, although you're going to find that the failure rate is going to be higher than if you're using the combo, and you're also going to have higher incidence of abnormal bleeding. It does decrease with time, but you'll find some people that have amenorrhea that happens there. So again, they may think that they're pregnant when really they aren't. It just happens to be that they're on the progestin-only product. And then that delayed return ovulation can be, again, problematic if they have a desire to become pregnant. Some different ways we can use this include things like postcoital contraceptives here. So these are kind of considered that morning after pill. You'll either see these be like estrogen only or like a combo of estrogen progestin there. Here you can find some progestin only products as well. Timing is really important for these. So if you have someone who had intercourse and they wait more than 72 hours, the failure risk goes up after that 72 hours. Within 72 hours, about 99% effective, which is good. So just this is an example of different ones that are there. I focus on the Plan B here because this is the one you can actually go and get from the pharmacy. At least in Florida, it does not require a prescription. You can just go and ask for it, and they can give it to you, which is good depending on the patient's circumstances there. One thing to note, though, is that when you're giving these really mega doses of progestins especially, you will see a lot of nausea, vomiting. And so if they vomit within an hour of taking that pill, they need to redose. And so that's why you want to consider giving it with an antiemetic, and that will help to reduce that risk for them having the vomiting there. So again, sometimes by giving a smaller dose and you split it up over 2 days, that can also help out with that potentially. So other things we're going to see reduced risk of include ovarian cysts, ovarian endometrial cancer, ectopic pregnancies, iron deficiencies, because if the patient's having excessive bleeding, this will help to reduce that. Acne, hirsutism, so a lot of other benefits that patients may be taking this for, not just for contraceptive purposes. They may not be sexually active at all, depending on the case there. So typically we will, for most patients, start out with a combo pill and try to use the lowest dose of estrogen we can. So usually about 30 to 50 micrograms of the ethinyl estradiol. It's the most common one you're going to see there. And then give a 3-month supply, see how they're going to do with side effects. Tell them, hey, stuff that happens early may not stick around, so see how they improve with time. Normally, you will start oral contraceptives on the first Sunday after menses. The reason why this is, there's nothing special about Sunday in the menstrual cycle, but what it helps to do is avoid withdrawal bleeding on the weekends. So that way, and again, what you'll see with these packs is they'll have 3 weeks of active pills and typically they'll have a week of placebo pills. And that placebo is basically having that withdrawal of estrogen and progestin that will then cause the bleeding to happen in the early portions of the week. By the weekend, the bleeding should be relatively minimal or gone, and then they can restart on that next Sunday. If the patient doesn't really care, or maybe they work the weekends, or whatever the case may be, there's nothing special about Sunday. They can start it whenever they want, really. Okay. Typically, post-pregnancy, you'll do about 3 to 4 weeks post-delivery in a lot of cases. And then if they've had an abortion, you can just start them up, again, that first Sunday after. They can start immediately after. There's nothing magical there. In terms of when you might want to recommend using alternative forms of birth control or maybe like backup methods, some people feel that during the initial cycle, maybe don't get complete inhibition of ovulation right away. You may consider just saying, hey, for the first pack, go ahead and use a backup form of contraception, use a condom or something like that. But again, it's controversial. There's no studies that say, yes, you must absolutely do this. We'll talk about what to do with missed pills. But again, the more they miss, the bigger the risk is for having ovulation occur. So obviously, if you want to have them take it like they're supposed to. And if they're on antibiotics or they're having severe diarrhea, that you're worried about that interrupting the enterohepatic recycling. And so then again, lower estrogen levels means more likelihood of having ovulation. So again, no studies that say you must absolutely do this, but the thing is if you're looking at the risk of using, using a backup form of contraception, there's really none. And then the risk of having potential birth, the impact that can have on a person's life, it probably would just make sense just to say, hey, use a backup form and you're fine. They have to know. They have to listen to you. Oftentimes they won't listen to you, but it just depends. Now, what to do about missed pills? Again, you want to make sure you're educating them on what to do if they miss a pill, because they might freak out or they might really have a worry about what's going to happen. So if they miss a single pill, just have them take it as soon as they remember. So if they normally take it 9 o'clock in the morning and it's like 2 o'clock in the afternoon, they can just retake it. There's no problem there, right? If they miss 2 pills, they can take 2 pills 2 days in a row, and that'll catch them back up to where they would normally be. That's totally fine. If they miss 3 or more, again, the risk for not having suppression of the ovaries is there, so they actually recommend de-seeing the rest of the pills and just restart on a new Sunday. Throughout the rest of the pack, we'll just get started the next week and no problem. So that's what normally is recommended in those cases there. So and again, I might have a test question that comes up and says, hey, patient calls you up and say, I missed 4 doses. What do I do? Right? Do you tell them to take 4 pills in a row, or do you tell them to wait till the next Sunday? You can kind of figure that out. So if they have a missed period, or they have that failure of withdrawal bleeding, and they say that they've had no missed pills during that first month, I wouldn't necessarily assume it was going to be pregnancy, right? So sometimes it could be the body's getting used to having this new set of hormones around. If it's after the first missed period, then yeah, you can tell them to go get a pregnancy test. I imagine most people will probably just go get a pregnancy test anyway, just because you'd rather be sure about that, but there you go. And then you can also have this phenomenon called honeymooning, where you can actually reschedule the menstrual cycle, which I had no idea you could do when I was in school. And I learned about it. I thought it was like I don't know, I thought it was like black magic or something they were doing there. But basically, you can just continue taking active pills until whatever occasion you have coming up, whether it's your wedding and you're going on a honeymoon right after, whether it's your spring break or graduation or whatever the heck you might be wanting to not have your period during, you can just continue taking active pills. So if you're at the end of one pack, you would just skip the placebo pills and start up a new one. And then when you come back from the event, once it's over, you can just, basically go back to the placebo pills, and then you can have, start a whole new pack if you wanted to. Alyssa's asking, do you have a higher chance of pregnancy if you take the 2 pills after missing, or is it coverage for that 1 to 2 days? So to catch you back up on those 2 days is generally going to be sufficient to prevent pregnancy. So I don't know that the risks are particularly any higher, but again, getting data to prove that might be difficult. Because again, you don't want to do like a randomized controlled trial and see how many pregnancies happen, because that would be pretty. I would not want to have anyone I know enroll in that kind of study for sure. But yeah, I mean, and if you look at the varieties of birth control that are out there, there are some where you only have 4 withdrawal periods during a year, or maybe you only have 1 during the year. So if you ever see like a seasonal or seasonique, they're designed where you're taking active pills for that entire period, that time period, and then you have the withdrawal bleeding, 4 times a year, 1 time a year. So there's nothing dangerous about doing that necessarily, but some people just like to be on their normal cycle, a normal 28-day cycle, and they have the withdrawal bleeding at that end of that period there. So it just depends on what the patient prefers. Some people they have such bad periods, they only want to do it 1 time a year, right? And so they just kind of hunker down and just deal with it for that 1 time, and then they're good for the rest of the year. So it just depends on the person. If someone is having breakthrough bleeding, generally, if it's during that first 3 months, it usually resolves on its own. And again, that's why you give them a 3-month trial to see how it's going to work. If it's still present, then you may need to consider changing up the specific formulation that they're on. So for instance, if they're having bleeding early on, like in the first 2 weeks, it's generally due to estrogen deficiency. So you can try to maybe use a product that boosts up the estrogen dose early on. Or if they're having bleeding during the 3rd week, it's usually due to a progestin deficiency. So you can try using something with a little bit stronger progestin effect during that later portion of the product there. So again, by switching up, for instance, and maybe going from like a monophasic to a triphasic that has a higher progestin dose later on during that month, that can help to mitigate that potentially. So those are just things to consider when going from like one product to another. If a patient says, hey, this really isn't working for me, and what can we do about it? So as I mentioned, you could use progestin by itself. So medroxyprogesterone acetate, or Depo-Provera, is probably the most common one people think about. So the Depo shot, if you ever hear that, it provides coverage for 3 months or so. Kind of gets injected into the muscle and slowly leaches out. Keep in mind though, and again, this could be both a good thing and a bad thing, that you still have some duration of action that goes beyond that 3 months, about 4 to 6 weeks or so. So that could be good if you have someone who's like, not very compliant with your regimen, and then maybe they're lost to follow-up for a period of time. You can try to get them back in that 4 to 6 weeks, and hopefully they'll still have the contraception prevention aspects of the drug. And then if you have people who want to become pregnant, again, they're gonna have a delayed return to ovulation, and so again, it has to do with the fact that drug just doesn't turn off at 3 months. It's still sticking around for a little bit of time. So again, if you have someone who needed or not needed, but they wanted to become pregnant in a certain time frame, this is probably not the product that's going to allow them to do that on their terms necessarily. So what if we wanted to avoid using systemic hormones whatsoever? Well, we can use things like intrauterine devices or IUDs. Here's an example of a levonorgestrel or Mirena. Usually some of the benefits here include the fact that they last for many, many years in a lot of cases. So for instance, you can put this into a patient for 5 years, and then they don't have to think about it for that whole time. Generally speaking, they will just kind of leach out drug in the local area, and they limit how much you're going to absorb systemically. It's not zero, but it's pretty limited as compared to taking oral contraceptives there. And basically, this is not going to do anything to suppress ovulation necessarily. What it's going to do is to try and make the environment very inhospitable for a sperm to come along and cause implantation to occur. So these can be very effective. You don't have to worry about compliance. One of the big things that you will, and again, the provider has to place this. This will not be done by the patient themselves, obviously. And you'll see that one of the things you may have patients follow up for is to make sure this is not accidentally, sometimes you can have transabdominal. I'm trying to think of the wording they use for that specifically. But basically, the thing can migrate out of the uterus and into the intra-abdominal cavity. It's rare, but it's pretty serious when it happens. It may require surgery to remove. So that's why sometimes you have patients who will need to come back in for follow-up, maybe like a week or two after this is placed, just to make sure that it's still staying in the uterus in the right location. And it's not going to migrate anywhere else. So one thing to think about. Here's an example of the ethinyl estradiol etonogestrel. So again, you see the estrogen and the progesterone there, called the NuvaRing. This can be placed intravaginally by the patient. Basically, it's in for 3 weeks and then 1 week out. And again, by providing local hormones, it helps to make the environment unlikely to cause implantation or conception to occur. But it's also, you're not getting a lot of systemic sort of hormones that may increase their risk. You're not going to see a big increase in your risk for clots, as opposed to if you're taking oral contraceptives, for instance. And again, if this is one of those products where if it fell out, you can just put it right back in, no problem, no issues with that there. Here's an example of a copper contraceptive here called Paragard. This is really interesting because it has no hormones at all. Like, so you don't have to worry about any kind of hormonal effects there. It also lasts for 10 years. So this is good for patients. Maybe they're done having kids after the first one and they say, okay, let's not worry about this for the next 10 years or so. You could do something like this, for instance, whatever the situation is. I've seen some cases where this can be used for emergency contraception. So if you had someone who needed coital contraception, this may be a thing here, but obviously this would not be as easy as going to the CVS and getting a plan B. The provider would have to do this. That's one thing to consider in terms of like access to care here. But again, this is releasing copper ions that actually help to impair sperm transport and fertilization. So kind of an interesting non-hormonal way of causing, preventing pregnancies from happening there. And so that's pretty much it. So that's the OB-GYN section here. This is the end of your testing material. I think I ended right on time, which is fantastic. Do you all have any questions, either about what we covered today or anything that we covered on sections 5 through 9? So anything from neurology, behavioral health, nephrology, urology, or OB-GYN? Big section. I think the first one we kind of took a little bit easier on. You only did 4 sections, and then the next 2 are gonna be 5 sections apiece. So that being said, there'll probably be about 10 questions per section, so that it should be pretty equitable amongst the groups here. And yeah, so just know your mechanisms for the drugs. If you understand the mechanisms frequently, you can understand the side effects for the drugs. Look at things like your pharmacokinetic interactions, like if something is an enzyme inducer or an inhibitor. Know how to manage side effects if they occur. So for instance, if you have someone who has an acute dystonia because they started taking an antipsychotic, what do you do for that, right? Yeah, so that's kind of the things that kind of popped in my mind in terms of what to think about for the exam. Would be pretty similar to the last one, so 50 questions, 4 randomized answers there. And if you have any questions that come up in the meantime, though, feel free to reach out to me via email. Don't post it to the sticky board because I won't check it until after the test next week. And yeah, any questions at all from you guys? Maybe someone, I know you guys watch it in a group in the lecture hall. Maybe someone can like pass along questions in the chat or something that might be useful. Or if you don't care, you can just leave. That's fine too. No problem there. So I just want to hang out for a few minutes just to see if anyone had any questions. I'm sure we haven't even looked at this stuff yet. We'll look at it during the weekend. It'll be fine. Which is probably true. Well, I'm not seeing anything, so I'm going to go ahead and cut it here. I hope you all have a great rest of your week. And again, please, the earlier you email me, the more likely I am to respond to you. So if you email me Monday night at 11:30 p.m., probably unlikely to get back to you. Email me tonight at 11:30. I'm very likely to get back to you. So, yeah, if nothing else, I will see you guys next week. Have a good one.